The key message is for me to really struggle to stay intraluminal. So you have much more options to treat the patient, to debulk the lumen and to remove the thrombus and hyperplasia.
Hello, this is a pleasure to welcome today Dr. Goyault from Strasbourg. We are today at the PVI, and he's going to talk about superficial femoral artery, and with the indication of the treatment of Rotarex plus DCB to treat restenosis lesions. Please feel free to introduce yourself and please tell us what are the key messages of your study.
Hi guys, thank you for the invitations. So I'm Gilles Goyault, I'm an interventional radiologist in Clinique Renard in Strasbourg. And the topic of my talk was occlusive instant restenosis treated with Rotarex and DCB. So it's a quite tough topic because there aren't any strong data on the subject. So how to deal with occlusive disease and occlusive stents, especially when there is involvement of the SFA, for example, just above and below. So the key message is for me to really struggle to stay intraluminal. So you have much more options to treat the patient, to debulk the lumen and to remove the thrombus and hyperplasia, so that you can more effectively treat this kind of occlusion. So don't hesitate to use Rotarex, of course, but other atherectomy devices, rotational atherectomy devices to debug this lesion, and then after treat with DCB, or if you need above or below previously implanted stent, another stent, for example.
Okay, thank you. And according to your experience, do you have any recommendations? For example, in which patients specifically do you indicate the treatment rather than another technique?
For me, the best indication for Rotarex are subacute occlusion, subacute or early chronic occlusion, when it's quite soft and there aren't any risk for distal embolization. So not in an acute setting, but really subacute. That means after 6 weeks, between 6 weeks and 6 months, I would say.
Okay.
And of course, there is a risk for distal embolization, so be very cautious and be very slow. So that means you should clean up, I would say 90 or 95% of the vessel before restoring flow. Restore the flow very lately at the end. Just keep a distal cap to avoid any distal embolization. Just at the end, open the vessel and restore the flow.
Okay, thanks. And are there any RCT on it, or is it something that is planned?
So far, these are only retrospective studies with cohort, multi-center cohort from French, for example, in 2020 that was published. But we're waiting for a meta-analysis that will come soon, I think next year, on this specific subject with the Rotarex used in subacute settings.
Okay, so it will definitely provide maybe more evidence and...
We hope so.
Mhm.
Or stronger evidence.
Okay. Thank you.
Thank you very much. Thank you.